I'm Spencer King, visiting with Dr. Davide Capodanno, who is from Catania, Italy, and is a major player in the European Society of Cardiology and in the Eurointervention Journal. And David, we're going to talk about TAVI. Obviously, everybody's watched TAVI go from the inoperable patient to the high-risk surgical patient to the intermediate low-risk. So the question is, are we done? In other words, without some subsets like dilated aortic root or some other situation, are we done with surgery? Can we conclude that TAVI is the best choice for everybody?
Thank you for the provocative questions. Of course, we are not done with surgery, and there are many unanswered questions that we need to address in the next years. And the first one is the durability of the bioprosthesis.
Yeah, because what do we have? What's the best follow-up we have on low-risk patients, for instance?
I would say that the follow-up is, first of all, in the patients who were implanted at the very beginning, so high risk, prohibitive risk, and at best it's like 8 to 10 years, I would say. The problem is that with these patients... They
were so old to start with, they must be pretty much gone by now.
Very few patients are alive, and that's the limitation. The competing risk of mortality on the outcome of durability is really jeopardizing all the calculation. So what we see is probably a number that will evolve and change in the next years. It's not really the true snapshot of what is going on with the valve.
So now that we go to lower risk, and low risk means the low risk study, as I understand it, did not have a lot of very young patients in it. Is that correct?
It's very correct. The mean age was always in the range of 78, 80, so they are not really younger.
Yeah. So to answer the question about younger patients, say below 60, below 65, 60, back in the 50s, how do we solve this problem? How do we establish that these valves are as durable as surgical valves?
Well, what we have learned from the surgical literature, first of all, is that when you are younger, the tendency to degenerate of the valve is faster because of calcification, because of reasons that are not fully elucidated. So if this is true also with the transcatheter valves, of course, this means that all the data that we have up to 8 years, 10 years, do not automatically apply to younger patients. So in the end, we really don't know, and this means to be very cautious now.
So that's an interesting point, because if you're talking about surgery now in the younger, even in the younger patients, it seems to me that the mechanical valves are falling way behind. There's not a lot of use of the mechanical valve. Even somebody, in the below 65, still they're going for bioprosthetic valves in large measure. So if the bioprosthetic surgical valve in a 60-year-old is better or worse than a TAVR valve, what can we use without 10-year, without 20-year follow-up? What kind of evidence do we have that gives us some guidance and what to advise to patients?
That's a very good point, because on one end, of course, the fact that some bioprostheses are used by surgeons at 65, etc., make some people think that the same apply to TAVI, which is not necessarily the case, because there are many reasons why TAVI could last less, but also some reason why TAVI could last at least as much as the surgical valves. So let's think that the way the valves is prepared is different, the leaflets are crimped, but at the same time there is less patient prosthesis mismatch, so we really don't know. We need some comparative data, and at the moment we have some 5-year outcomes that comes from the early pivotal trials of the balloon expandable, the self-expanding valves, but the best follow-up that we have is 5 years for the 2 pivotal trials, let's say in high and intermediate risk, and we have 6-year outcomes from the Notion trial, which was an investigator-driven in low-risk patients. But this is what we have.
And as far as I know, there's no surrogate endpoint that we can really count on. Like if you could examine a valve with imaging of various sorts at 5 years, and look at surgical valves and TAVI, you should be able to say, well, this one looks better than the other one. But as far as I know, there's nothing that we have evidence there that would help us project. What we're trying to do is project 20 years. Is no way I know you can do that, is that correct?
No, the only thing we can do is to run bench testing somehow and try to open and close very rapidly the valves for life cycles. This has been done, of course, but yes, it's very difficult to extend this to the human body. It's a totally different story. In Europe, I must say that at the very least there was a kind of effort in standardizing the definitions and include echocardiography as well, because of course when we define durability only as a reoperation, we miss a lot of events, of course. So now that we understood that echo should be there, the question is about the optimal cutoff values to define structural valve deterioration. In the end, I think what is very important is what matters to the patient, the so-called bioprosthetic valve failure, which is typically the composite of mortality related to the valve degeneration, reoperation, and severe structural valve deterioration.
So patients are very interested in having TAVR, obviously, and they're lobbying for that. They want to know why they shouldn't have it, if they should. And I guess the temptation is to say, well, look, regardless of whether you have a surgical valve or a bioprosthetic valve, maybe you're young, this is going to fail sometime, but no problem. We're just going to pop a valve in valve and you're going to be okay. Is there anything about, certainly if you had a mechanical valve put in surgical, there's no way you're going to do TAVR. Is there any advantage, I'm wondering, is there any advantage to TAVR or surgical valves in terms of being able to do valve and valve down the road?
Well, let's say that, of course, with both surgical and transcatheter valves, you have the option for a second TAVI later in life. But of course, this is not for granted because it depends on the dimension of the annulus, the access to the coronary arteries. So in a way, we should start to plan a kind of a valve journey for the patients who are younger and imagine what happens in 10 years from now, 15 years from now, if we need a second valve. And this kind of reasoning now is becoming more and more important at the time of deciding for one procedure or the other. So this kind of consideration, I think, will dominate the debate in the next few years.
So something like a low left coronary artery takeoff that might be on the borderline. You say, I think I can do TAVI, we have no problem, but I'm
the
a
first
little
one.
on the line.
Exactly,
yeah,
but then the second
But
you
then
don't
if
know.
I have to do again, maybe that might be one young patient you might say, surgery might be better.
I think this kind of consideration should really be part of our team decisions, including also the issue of patient-prosthesis mismatch, because sometimes some patients are directed towards surgery, but then the annulus is very small. So if there is no annulus enlargement plan, this patient will end up with a gradient, and that would be a problem. So this kind of issues should be discussed really at the time of deciding for the first procedure.
So 5 to 10 years ago, this idea, this question of durability would be one that we would all say, yeah, but we got to watch out. These may totally fall apart. Now, we're stuck with a problem. They're doing so well, that we still have to ask that question, what about the durability of the whole process and which patients might be best suited for surgery up front, because it's clear that we're going to move away from these 70 and 80-year-old patients to younger patients that are going to challenge us in that decision without a lot of hard long-term evidence, but still we have to make a decision.
Let's say so far so good, up to 8-10 years, and then time will tell.
Thanks for sharing this with us.
Thank you very much.